watch you from like this on YouTube.
Okay. That's an extra message on video. Anything, I've got all the. I don't think it's breakfast. Usually they don't post anything on YouTube. So if I
You're just going to show up to add on the mic. Left in his room.
I never followed the YouTube link.
I don't know, it's not so science.
That's yes.
That's the usual we advertise for 31 people start dribbling it.
Okay, so. Give it a few minutes.
All right.
So I don't have to come there at all.
Yeah. I was going to say, if you go
Oh, that's nice.
well, they
Okay.
those
Okay.
come along. They really feel. It's not just you know,
It's light right now. You can not stop.
I did see that. I did watch it. I just told you I was just curious if there's anything yeah. So I used to do that, it's pretty well, it's the compromise people.
Yeah.
I don't know.
That's what I was wondering. I've got enough. Yeah. I was talking
Hello, Nick, how are you?
I'm good. Sorry.
Good.
Good, how are you?
Yes, definitely, definitely.
They don't go away with it.
Oh. Yes.
I'm aware of it.
Hi.
You don't have to.
We must jump down. You just like it. People were trying to like.
Okay, good afternoon, everyone. Good afternoon, welcome to NIWA in Auckland, and welcome to our viewers online. This is the latest of our series of webinars brought to you by the International Wood Smoke Researchers Network, which we are leading here at NIWA under funding from the Ministry of Business, Innovation and Employment. And today I'd like to introduce Dr. Curtis Noonan from the University of Montana. Late last year, Curtis's collaborator, Tony Ward from the University of Montana, gave a talk on this series, which is still available on our website. And this is pretty much, I have a companion piece focusing a little bit more on the health effects of wood smoke. So with that, I'd like to hand over to Curtis Noonan.
Right. Thanks, Ian. Thanks to NIWA for providing this opportunity for me to visit and to share some of the experiences that we have had in communities that use wood for domestic heating. So it's interesting to visit here and learn about some of the similar issues and challenges in the New Zealand rural communities that have the same type of sources of particulate matter exposure. So it's been really a great opportunity. So and yeah, as Ian described, I'm going to hopefully not repeat some of what was shared earlier through this webinar series by my colleague, Dr. Tony Ward. I'm going to focus more on some of the health outcomes of some of our studies and some other similar studies related to trying to understand the health impact of interventions that target wood stove communities. So just to give you a sort of a brief overview, I thought I'd just start out with this question. You know, why do we care about trying to describe the impacts, the health impacts of efforts to mitigate wood smoke exposure? We already know a lot, you know, thousands and thousands of papers published about particulate matter and health. So is there more to be learned from looking and engaging with these communities that are exposed to a very particular source of particulate matter, that being biomass smoke from wood heating? And so I guess I would say, yeah, primarily the issue is that the health-based standards, you know, upon which, you know, we use as our indicators of whether or not a community is exposed to levels of pollution that might be of health concern. Those health-based standards rely primarily on studies, particularly, you know, or more often than not, observational studies in urban areas, where the sources can be quite different, and exceedances in these urban communities can often be attributed to either mobile sources or industrial sources, as I'll show, share with you in a moment. You know, even these sources have declined over time through various policy and technological advances. But in rural communities that we're discussing here today, and that's sort of the main topic of this particular webinar series, the exceedances in these rural areas are due to domestic sources. So we might just take the sort of precautionary principle, and I think it's reasonable to do so, and assume that there's no difference in terms of the health impacts of particulate matter from an urban source versus particulate matter from a domestic heating source. But we also have to recognize that, in these communities, this type of, heating with wood has also economic, social, and even emotional considerations in terms of how we suggest or develop interventions to address the issue. So I think it's reasonable for communities and homeowners to ask these questions about is this really a health risk? So some of what I hope to share is that we know a little bit about that, but there's frankly not a ton of studies that have specifically looked at health impacts from interventions that are targeted at biomass heating in higher income country settings where wood is used as a source of heating. So what I'm going to focus on are experimental studies that can help to show impact of policies or interventions or actions that specifically target wood stoves. So first of all, I'll describe a little bit about a couple of natural experiments, focusing particularly on one of the studies that we did in a small community in northwestern Montana, where I come from, and then talk a little bit about some controlled experiments that have been done, including a focus on a study that we recently completed, a randomized controlled study that we recently completed. So before we dive into natural experiments, I thought I'd go back. The study now goes back a few years now, and probably is not thought of as a natural experiment. But this is a well-known study that I'm sure many of you are familiar with. But in a sense, it really is sort of a natural experiment. This study was targeted at trying to understand how changes over time in many U.S. communities and reductions in PM that occurred over decades periods, how that had an impact on a really crude measure of health outcome, in this case, life expectancy. So I'm just going to sort of refresh your memories on that so that we can kind of get a sense of how they approach this. So this first graph from the 2009 study by Pope and Azadi and Dockery shows in dozens of communities the PM levels in the period 1979 to 1983 contrasted with life expectancy in those communities. And the only difference between circles and dots is whether or not they are metropolitan areas or county level areas. So as you can see, there's this inverse association between PM exposures and life expectancy. Fast forward now to the period 1999 to 2000, and you can see, I'll just back up a second so you can see the levels on the horizontal axis, so the range being anywhere from 10 to 30 microgram per cubic meter of PM 2.5. And then when we fast forward to the period 1999 to 2000, all of those PM levels, or a lot of them, shifted left, right? And so that was due to a variety of factors, some policy driven, some just economically driven, some engineering improvements in vehicle emissions, et cetera. So there's been, overall, on average, a large improvement in these U.S. communities, again, primarily urban, in terms of the ambient PM 2.5 levels. Yet in the relationship, even in this 1999 to 2000 period, the relationship between PM 2.5 and life expectancy remains. So the intriguing thing that this paper did is that they decided to look at the change in PM 2.5 from the first period to the second period and how that was related to life expectancy. So each of those dots are showing on the horizontal axis, the change from one period to the next, the reduction in ambient PM 2.5, and again on the vertical axis, life expectancy. So overall, despite lots of noise in these data, they demonstrated that PM 2.5 decrease of 10 microgram per cubic meter yields a life expectancy increase of 0.6 years, which by itself doesn't sound like very much, but extrapolated over the large populations in all these metropolitan communities, it adds up to quite a lot of person years. Looked at another way, and we know that over time, life expectancies in the U.S. and many other most other higher income countries, life expectancy increases over time. So in this period, the increase in life expectancy was 2.72 years. If we then look at the corresponding reduction in PM 2.5, again, this is across this large number of communities, it was about 6.5 reduction in PM 2.5 in terms of microgram per cubic meter. So that translates to the life expectancy gain that's attributable to that change in PM 2.5 was 0.4 years. And again, that number just thought of in isolation doesn't seem like a lot, but applied to over these large populations, it's a substantial outcome in terms of following this natural experiment or this natural change. There's not really a natural change. Again, this change in PM was driven by many factors that I described previously, but this analysis is just a good example of a natural experiment. So the Health Effects Institute, which is a funding agency in the United States, supported several what they called accountability studies. This is just I might use a term natural experiment as another way to look at these, but what impact was realized through some interventions that were related to reductions in either PM 2.5 or other sources of air pollution. So that last one is the woodstove changeout study is a study that we got funded to do, and it was focused on the small community of Libby, Montana, which is located in the Rocky Mountains of the United States. Very small community, in many ways very similar to a lot of communities that I've seen here in New Zealand. There's topographical features that result in this sort of valley effect. There's meteorological conditions that result in inversions. So in these small communities where a high proportion of the homes use wood for heating, it can lead to elevated levels for long periods of time, elevated levels of particulate matter. So here's a simple figure just to give you the overall picture. These are monthly averages of PM 2.5, ambient PM 2.5, and you can see the classic seasonal variation here with winter periods having higher exposures than the summer or the warm temperature periods. If you see little blips that fall into the sort of August period, those little blips and just to clarify, August is still summer for us, not here. But so if you look at those increases in August, those are forest fires, which are a big seasonal exposure in our part of the country. But more or less, what you can see here is that the big problem is exceedance of the annual standard in communities like this. Less so exceedances of the daily standard. Although, as you'll see later, there are exceedances on a given day of the daily standard. Again, these are just monthly averages, so that doesn't really show those exceedances. But I'll show you a figure that does in a moment. All right, so this was a problem for this community, so they received lots of resources through a variety of avenues to address this problem in this small community by engaging in a large-scale woodstove change-out program. Other terms that are used for this are woodstove exchange or technology upgrade. They're all interchangeable terms in my view. And so The approach was to pull out old, inefficient wood stoves and replace them with what we call EPA certified wood stoves. So these are wood stoves that are certified by the US EPA based on a metric that's used as 4.5 gram emissions of 4.5 grams per hour. And I know in other countries, different emission standards are used. And here in New Zealand, it's emissions on a gram per mass of fuel burned. But you know, in essence, it's sort of some sort of measure that indicates whether or not this stove has, you know, is adequately efficient according to that particular standard. So this project was implemented through a variety of voucher systems and some enforcement. And again, they had lots of money to allocate towards this program, or, you know, $2.6 million for a community that's probably, you know, in the range of 4,000 total population. So here's a figure that just shows how the ambient PM 2.5 changed over time. So just to walk you through this figure, the red line is just showing how many stoves are changed out over time, starting, you know, with 0 up to the point where the program began in some point in 2005. There was a relatively quick ramp up, and then there was you know, sort of a tailing off of the number until they reached the total number of wood stove changeouts, which was around 1,170 or 1,175 wood stoves. The small circles, which might look like dots to you if you're looking on your computer at home, those are just daily measures of ambient PM 2.5, and the dark line is just a rolling average of ambient 2.5. So the first thing you can see here is that there's a lot of variance, obviously, from one day to the next, and you can see what I had implied earlier, that there are on a given day there are exceedances of the US 24-hour standard of 35 microgram per cubic meter. And if you look at those first 3 winters, those first 3 peaks, you can see that after the wood stove program began, those peaks have been somewhat, you know, mitigated, although you still see a lot of variability in the day-to-day measures. But overall, this program did achieve its goal of reducing wintertime ambient PM 2.5. So this is just giving an indication for those 2 winters that were before the program began. The ambient PM 2.5 was 27 microgram per cubic meter. And in the 2 years after the wood stove program was completed, it was down to 19.7 microgram per cubic meter. So they did actually meet the annual standard, which was considered a success. But as you can see, there's still, you know, relatively high levels and a lot of variance on from day to day. So what we did, and what we were funded to do, was to observe some health outcomes while this program was going on. And so what we chose to do is collect data from parents, using schools as a pathway to connect with parents, to report on symptoms and illnesses of their children. So we engaged with the 3 schools in the community. You can see, at least in that picture of the middle school, this is a heavily forested area, so you can see why, you know, wood stoves are commonly used. You can also see in the picture for the high school that logging or forest harvesting is a huge is a big tradition in this community. So wood forest is you know, has a really important economic and emotional connection with this community. So we collected these surveys over 4 winter periods. We queried on a variety of symptoms and health conditions. Our response rate wasn't great, admittedly, but we were still able to discern some changes over time. So this is just some summary data of reporting of wheeze in the first column across these 4 years, and that was our main, let's call it our primary outcome that we were interested in. as an indicator of children's health effect. You can see that ambient wintertime PM 2.5 in the next column over. Temperatures, and then flu. We knew that influenza seasons are something that can be, can really be indicative of how sick a given population, particularly children, can be from year to year. And we know that that varies from year to year dramatically, depending upon flu strain and a variety of other factors. So we felt it was important to control for that factor, and to do so, we just captured information from the hospital for influenza testing. So this was our model, and it's a pretty simple model because it's a pretty simple analytical problem that we were tackling. If you really, uncover the layers of this, we really had 4 data points, right? So for a given outcome, right? We were looking at one winter to the next winter to the next winter to the next winter. So 4 winters where we had some measures of frequency of outcomes for each of these winters, and then we had PM 2.5 data from the ambient monitoring. So we were able to show modeling on about 5 microgram per cubic meter reduction of PM 2.5, which is we picked that number because it was about what they saw over that 4-year period. And so we were able to show, at least with some statistical robustness, we were able to show that reported wheeze was reduced by 27%, and reporting of irritant symptoms was reduced by about a third. So these other symptoms that we asked about are the types of, in addition to wheeze, are the type of symptoms you would typically ask about for asthma response. But those other, we didn't see strong signals from any of those other symptoms. Looking at conditions, respiratory conditions, we did see reductions for cold and bronchitis and throat infection, and pretty substantial reductions, although it's, these are all statistically significant observations, but there's, as you would expect, there's a lot of variance around these estimates. We didn't see a significant signal for middle ear infection, and that, which has been observed in other studies for, the relationship between PM exposures and ear infection, but that typically is something that impacts infants and very young children, and of course our population was school-age children, so that could be the reason that we didn't see it in this particular study. So that was an example of us doing a natural experiment, just following a change that happened in a community that was where the intervention was focused on changing or upgrading the technology of the wood stove, the wood burning appliance itself. Another approach that has been used in communities is fuel switching. And so just to bring up a historical example, was the coal ban in Ireland. So there's been some studies, and one of the studies funded by the Health Effects Institutes was tracking changes in health, before and after the coal ban in Ireland, primarily in Dublin, I believe. Tracking along with trends in fuel switching amongst some higher income countries suggests that there could be more biomass burning, although this is variable in terms of what's happening from one country to the next. But in some cases, and this was particularly true during the many years of the recession, people were making economic decisions about home heating. And there are some areas where there are incentives for promoting wood as a heating fuel source, particularly in Europe. I know that's not necessarily true here in New Zealand, but there's there are these trends from place to place. So the second example of a natural experiment that I want to share with you has to do with, occurred in Australia by Faye Johnson and colleagues. They followed a population where there was a large-scale fuel switching program. So this is a much larger community than the Libby, Montana community that I shared with you. And this was a program where they were replacing wood heaters with electric heat through a variety of mechanisms, marketing, education, and some enforcement. And so they tracked outcomes both in terms of ambient PM2.5 and mortality outcomes over the period before and after the this fuel switching program, which, obviously the fuel switching program occurred over a long period of time, but they use as their line of demarcation of pre versus post around the 2001 period. So this is a busy figure, but just to walk you through the figure from Faye Johnson and colleagues, there's the blue line is showing the standardized daily mortality rate. It's difficult to see just looking at that, where the changes are occurring from the pre to the post period. But if you can focus your attention on the little black bars at each winter period, that does demonstrate the change in ambient PM 2.5. Those are, I think, medians or actually they're winter means for ambient PM 2.5. And you can see clearly that there was a reduction after this fuel switching program that averaged out to about a 38% reduction. So they were able to show during this pre to post period that there was a reduction in all-cause mortality, and this is annual mortality, for more so, or at least more robustly, for cardiovascular disease compared to respiratory disease. When focusing just on winter period, which of course is the relevant period for this, there is less significant or less robust observation of reductions in cardiovascular disease mortality and respiratory mortality. So these are grouping large causes of death into these general categories of cardiovascular and respiratory. Intriguingly, they did not see any change in women's mortality, so that's a bit puzzling. But importantly, they were able to demonstrate that there was no corresponding reduction in mortality in a comparison community that they tracked as well, which is great to be able to show that there wasn't some overall temporal trend that they were just reflecting here. So this was a really important study, particularly for demonstrating the cardiovascular effects and impacts on mortality. So switching now to controlled experimental studies. So there have been a few chamber exposure studies. So these are exposure chambers that are specifically designed to deliver wood smoke to humans in a safe setting. And there have been a few of these. We've done one of them. That third paper indicated there is one that was done in our exposure chamber. And these studies show some indications of increased inflammatory response, but admittedly, there's inconsistency across the studies in terms of what exposure to biomass smoke to healthy people exposed to biomass smoke results in terms of acute response. The other type of controlled experimental studies would be that are relevant to our discussion here have been done in lower income, middle income settings where wood is used in cook stoves for sometimes both cooking and heating, but predominantly for cooking in these settings. And there have been three studies, three large studies. There are several others but just as examples, there's the Respire study in Guatemala, the Malawi CAPS study, and then the GRAPH study in Ghana. We're still waiting for results from those. So I'm not going to focus on those because, again, this talk is really about higher income country settings where wood stoves are used for heating. But I just wanted to give you some context that some of these randomized controlled trials are happening in those settings as well. So the two types of studies I'm going to focus on in terms of controlled experimental studies are crossover filter studies and placebo-controlled trial in children with asthma that we conducted. So first, starting with the filter crossover studies, and this was done by a group in British Columbia, where they randomized households and people to either getting a filter on condition first and a filter off condition second, or vice versa, getting the filter off condition first and the filter on condition second. So the nice thing about these types of crossover studies is that each individual serves as their own control because they have both conditions. It's a good design for looking at acute effects, whether you're looking at some subclinical measures or some biomarker responses. And so that's what this study was focused on, looking at some biomarkers and some sort of a subclinical measure of endothelial function. And so they did demonstrate that the filter on condition was associated with improved endothelial function and decreases in some inflammatory markers. So these particular outcomes are related to some of the biological pathways that are suspected to inform the relationship between PM exposure and cardiovascular health. Subsequent studies using this similar type of design have not been entirely consistent. These are all relatively small studies, but it is one type of study that can be, deployed in home, interventions where the intervention is at the household level, where you just want to look at an individual level effect. So moving on to the controlled experimental design that we have focused on, that we have been conducting over the past several years and recently wrapped this up. Our study, which we call the ARTIST study, is a randomized trial of indoor wood smoke focused on children that have asthma, that live in homes that with wood stove as a primary source of heating. It was a 3-armed placebo-controlled study. So we had what we called sham filter, or an inactive filter that was our control arm, air filter arm where we just use these plug-in filtration units in the home, and then we had a wood stove change-out arm, similar to the approach that I described for the Libby community. So in this particular study design, obviously the sham filter serves as the control arm in comparison to the 2 intervention arms. So this study quickly learned that it's very challenging to find participants meeting all of these criteria, so children that have asthma that live in a wood stove home. So we branched out into numerous communities to get to our targeted sample size, and so it was a good learning experience for us in terms of logistically conducting studies in multiple sites. We just to give you an idea, so each of those bars, if you will, would be sort of a cohort of pre and post measures. So each home would participate in our study for 2 winter periods. The first winter period being the opportunity for us to collect baseline measures. The intervention, according to which arm a home was randomized to, would occur in the intervening period, and then the second winter period for a given group of participants would occur. We would measure the post-intervention measures. So these are the health measures that we conducted at each home. We wanted to know, did the intervention result in an improvement in quality of life? And there's a instrument that's used for these for assessing quality of life in children that have asthma. It's called the Pediatric Asthma Quality of Life Instrument. It's a 23-item questionnaire where you sort of query the child about, how well they're feeling about a particular activity or a particular symptom. And it's broken down into domains of symptoms and activity limitation and emotional function. The other main health outcome measures that we collected were peak flow monitoring. So we trained the children in capturing peak flow measures using an electronic handheld device. These were children that had asthma, so they were pretty familiar with this type of instrument. So we trained them to conduct 2 measures each day for a 2-week period for any given sampling visit. And that instrument recorded percent predicted peak expiratory flow, percent predicted forced expiratory volume in the first second. And then from those data, from the peak flow data, we were able to calculate diurnal peak flow variability, which is an indicator of airway hyper-reactivity. So we also collected, lots of different assessments of exposure. I'm only going to focus on our indoor PM 2.5 measures that were collected, but you can see we collected a variety of other measures and exposure factors that were considered in our analyses and in sort of corollary studies. So this is just to show you a picture. So what I just described in terms of the health measures and the exposure outcomes, that's what we would call a visit. And so we would do in each home with each kid, we would do 2 visits in each of 2 winters, right? So we'd have 2 baseline pre-intervention assessments, and 2 in the subsequent winter, we would have 2 post-intervention assessments. And so the sampling period at each visit was a 48-hour indoor sampling period. The quality of life instrument that I described earlier was reflective of the week prior to our sampling visit. So we would ask children about, like, during the past week, how did this impact you? How did you feel about this? And then the peak flow monitoring, the last arrow on there was conducted for a 2-week period, starting with the day of our initiation of the indoor air sampling. So our statistical analysis is a randomized controlled trial. It's standard to do intent to treat analysis. We achieve this by using a linear mixed model because we have repeated measures. And we wanted to be able to adjust for certain factors, at least age and gender. And then we also did some sensitivity analyses, which I'll show you in a moment. So here's for a trial or an RCT. This is the standard sort of figure that you would see in a paper like this. And we had 115 that were randomized. We lost one of those subjects. Didn't have even, I think they moved, so we didn't even have sufficient baseline data to include them in subsequent analyses. Indicated here, you can see that we had lots of measures. So, for example, if you look at that air filter group, the third or the right-hand most group, we had 46 participants in that were randomized to that arm, and 91 sample events. So we have repeated measures on all of these kids. Well, and I should say that's 91 sample events for just the pre-intervention, and then another 78 sample events for the post-intervention period. So overall, 114 kids, 414 observations. So those are 414 of those visits I described earlier that have both health and exposure measure assessments. Mean age was around 12. close to half and half female and male. 89% were classified post hoc as having moderate to severe persistent asthma. Our intent at the beginning of the study was to only include children that had moderate to severe persistent asthma, but our screening tool to evaluate this was not perfect at being able to distinguish this. So we were able to reclassify people according to some of our more robust health outcomes measures that we collected in the course of the study. But still, almost 90% of them did have moderate to severe persistent asthma. And I'm going to show you our, this is just a density function. It just kind of smooths out the data for visual purposes, showing you for each arm. So going from left to right, the air filter group, the stove changeout group, and then the placebo or the sham filter group, with the solid line being pre and the dashed line being post. So you can see just there's certainly a clear shift to the, to reduced PM in the air filter group, only a slight shift in the stove changeout group, and then basically no effect in the placebo group, which is good. Those values on the horizontal axis are logged PM 2.5 values, so just for analysis purposes. So the important take-home message from this figure and the data about indoor PM 2.5 is that we saw a really consistent from home to home reduction in PM 2.5 in the filter arm. So about a 67% reduction in PM 2.5 in that air filter arm. The wood stove change-out group, and this is consistent with some of the other studies we've done and probably some stuff that Tony shared in his talk. We did not see a consistent reduction in PM 2.5 for this, introducing a new, more, a better technology wood stove into the home. In fact, this particular observation was so disappointing for us that about 3/4 of the way through the study, we actually discontinued this arm in our study because it wasn't demonstrating efficacy, in addition to being a very expensive and cumbersome intervention at the household level. So what were our health observations in this study? Well, we were able to show that when we look at the wood stove arm relative to placebo, or the air filter arm relative to placebo, that's what this table is showing us, we did not see any improvements in quality of life measures. Okay, so whether we're looking at, we did see across all three arms, including the placebo arm, improvements in quality of life. But when we look at the intent to treat analysis, right, which is really the sort of the efficacy you're trying to demonstrate, we did not see any improvements in quality of life relative to placebo for this particular measure. So with our peak flow monitoring, here you see again the mean change. So if you just focus on, maybe ignore the wood stove change out arm for now, but if you just focus on the air filter arm showing the mean change and 95% confidence level, this just shows the overall change of going from pre-intervention to post-intervention relative to the observed change in the placebo group. Okay, you can see that we have a lot of variance, right? And we didn't have really strong findings except for this last measure of peak flow variability, which again is an indicator of airway hyper-reactivity. We show that our air filter group, the peak flow variability was reduced by 4 percentage points relative to placebo, and that's a good outcome. So for a child with asthma, you want less variability. That's indicated. That's an indication of better control, less airway hyperreactivity. So this demonstrated for us some efficacy in this particular measure of peak flow variability, but not backed up by other measures of our of either forced expiratory volume or peak expiratory flow by themselves. So we were also interested in whether or not asthma severity had any impact on our overall analysis. So we did do some sensitivity analysis and broke these individuals down by the type of asthma that they had according to our use of some of our health outcomes that we collected and translating those to the NHLBI guidelines for determining severe, moderate, or intermittent asthma. And as you can see, perhaps not surprisingly, the group in the lowest row there that had mild or intermittent asthma did not demonstrate a strong efficacy in this particular measure of peak flow variability. So that may have, sort of further attenuated our failure to restrict our population to those that had moderate to severe asthma. May have resulted in some attenuation of our observation at least for this peak flow variability measure. So just to summarize this particular study, the assignment to filter arm was associated with strong and significant reductions in indoor PM 2.5 concentrations. Not true for the woodstove intervention arm. Our quality of life measure did improve for all of the three arms, but that's not really what we were interested in seeing. What we really wanted to see is that the intervention improved, filter intervention improved quality of life among these children with asthma, but it really did. We're not able to demonstrate that. We were able to demonstrate that the children that were in the homes with air filter did have improvements in peak flow variability relative to placebo. So a variety of strengths and limitations from this study. It is a randomized placebo-controlled trial, and that's when people talk about evidence-based, at least in the clinical world, that's what they want to see. Nevertheless, in a household or environmental intervention setting, these are hard studies to do. Nevertheless, we had a pretty large study for this effort, over 400 multi-day exposure and health sampling assessments, 114 children with asthma. It was conducted across many different regions of the country. We collected extensive information on a variety of indoor exposure sources and metrics, lots of different asthma measures and relevant covariates of the participating children. Some problems potentially are that the participants in the woodstove changeout arm were not blinded to assignment, right? So by having the sham filter, we were able to some degree to blind households and children to their treatment arm if they were in the filter arm or the placebo arm. But obviously the households that were in the woodstove changeout arm were not blinded, right? It was pretty clear if someone came in and tore out their stove and they put in a new stove there, that they had that intervention. It's fair to criticize the collection of spirometry or the peak flow monitoring data. And it is a measure that's effort dependent, right? Again, we trained our children repeatedly. Children with asthma are pretty used to using an instrument like this. Nevertheless, it's a fair critique. We like to think that by looking at peak flow variability, which is looking at relative changes in the same measure, that we're somewhat protected against this particular criticism, but I think it's still a fair criticism. We did have some imbalance in our three arms. One of the great features of a randomized trial is that you would expect, if your sample size is large enough and your randomization strategy is strong enough, then you would be allocating equally across the different arms the covariates that you're concerned about and the unmeasured covariates or potential confounding factors that you don't even know about. in this particular study, and this is partly true because we stopped the woodstove arm early, we did see, at least with respect to the woodstove arm, that those kids turned out to be a little bit, on average, have a little bit higher PM exposures in the homes and had more severe asthma at baseline. Again, I don't think that really impacts the observation of our filter arm relative to placebo, but it's still a concern when we're looking at the woodstove arm. And then, we did measure lots of things, so we're always concerned about multiple comparisons. So just to wrap up this thought and to give you an idea of where we're headed now, or what we're in the midst of right now, we have 2 current randomized controlled trials. I know Tony briefly mentioned these, but these are working with communities to adapt behavioral and educational interventions. And so we do videos and storytelling instruments that are developed and informed by the community about best burn practices, about, in some cases, the importance of wood burning in their communities and in their traditional histories. These are studies that are conducted in both Native American and rural communities. We also provide homes with best burn practice tools. These would be things like a wood moisture meter or stove thermometer. And then in one of our 2 studies, we support the building and sustainability of wood yards that are used to deliver wood to elders in their communities. So just looking at what the health outcomes that we focus on in these 2 studies. Our elder study, we focus on pulmonary and cardiovascular health measures. And our kids study, these are kids that are all less than the age of 5, we focus on reducing the incidence of lower respiratory tract infection, which is an important outcome in terms of morbidity, and it's very parallel to some of the studies that are done in the developing countries where cook stoves are the exposure factor of interest, and the outcome of pneumonia, one of the most important lower respiratory tract infections, is a key contributor to childhood mortality in those communities. So just overall, sorry for all the words here, but I was, I sort of got on a writing streak this morning, but community-wide efforts to replace conventional stoves via technology upgrades, fuel switching, have been marginally effective in reducing ambient particulate matter. But we have limited data to show this, and if you think back to those graphs and figures, they're still moderately elevated ambient PM 2.5 even after having met those reduced levels. The promotion of wood stove technology upgrades is a very common thing in communities in the United States. It's promoted by our federal agencies, our state environmental quality agencies, and by communities. But I think we need to consider the efficacy of that particular intervention. I know in our hands, for our particular study, it was not demonstrated to be efficacious. We ourselves have seen lots of variability in how impactful that is in terms of indoor air quality, despite the fact that in a couple of the community-wide efforts, we have seen reductions in ambient air quality. And then also that intervention approach also needs to be, we need to consider, the high cost of that particular type of intervention, and what I like to describe as the near permanence of that intervention, right? So if it turns out that intervention is not the best intervention, we've sort of committed that household to having that intervention for decades to come, perhaps. The in-home filter interventions are more consistent in lowering indoor PM 2.5. That intervention does not come without its caveats as well. There's some, although modest, cost of electricity. There's concern among our participants about noise, and then there's concern by us about the sustainability of that intervention. How long will people continue to use that filter in their home? What's the compliance? What are the compliance levels? And we've done some work on that and assessing how incompliant home needs to be in order to still demonstrate an effect. And they actually don't need to be all that compliant, to be honest. But years down the road, will they still be using that? We don't know. We're doing a lot of work right now on behavioral change and introducing tools for best burn practices, and it's being promoted by a lot of others. But we don't really know. It's not tested. We don't know how well that works. That's where we'll hope to find that out. But a lot more work in that arena needs to be done. We were able to, so a variety of the health studies I described to you here, and there haven't been a lot, right? There haven't been a lot of health studies that have really focused on trying to figure out what happens when you implement these interventions in these small and sometimes even large, in the case of the Australia study, communities. So more work needs to be done there, because there's some evidence of benefit, but there's just few studies with varied outcomes that are being assessed. So I think, and even any one approach or any one outcome has not been observed repeatedly or studied repeatedly. Natural experiments are perhaps appropriate and realistic in settings where it's a community-wide intervention, where you're going to see some signal in the ambient PM 2.5, but difficult in a case where the intervention is a little more spotty, and you might see more localized rather than community-wide effects. And the detection of mortality effects, which I know is a really important measure for people because it's easy to understand. Studies that are focused on that may be limited to really large communities, like, again, the Australian study. In the smaller communities, it may be more difficult to detect a signal in mortality change. But there's still opportunities to focus on studies of biomarkers or clinical measures. So finally, just to acknowledge our study team, and there's lots more people that are involved in all of these studies that we conducted. We also want to acknowledge our funding agencies, both the Health Effects Institute for the Libby study and the NIEHS, National Institute of Environmental Health Sciences, which is part of NIH, that supported our asthma study and our current randomized control trials in elderly and children. Finally, just a plug for our School of Public and Community Health Sciences at the University of Montana. We're now hiring an assistant professor of epidemiology, so contact me if you're interested in that, or just search that out if you have any interest. So thank you, and I don't know if we have time for questions.
Thank you very much, Curtis. We have one online question, but I'd also like to invite any questions from the room, first of all.
Let's go on.
Let's go online. So this is quite a lengthy question, so bear with me, but I think that's a good one. Launceston's efforts to reduce PM 2.5 pollution by switching to non-polluting heating were much more successful and cost-effective than the Libby's program, in which the majority of old stoves were replaced with new ones. The final report in 2015 evaluating British Columbia's woodstove exchange program noted that over $2.2 million had been spent without achieving any clear reduction in wood smoke pollution in BC. Thanks to the recent efficiency improvements, modern heating air conditioners are cheaper than buying a wood heater, cause less global warming, and have lower running costs than buying firewood. Given the much greater benefits and success of replacing wood stoves with non-polluting heating, should future wood smoke programs follow the example of the San Francisco Bay Area's Spare the Air, Cool the Climate, but to reduce emissions of particulate matter and black carbon, we will also need to eliminate wood heating?
That is a long and loaded question. Yeah, I mean, instinctually, yes. I mean, it would be great to eliminate biomass combustion as a heating source. I think the challenges that we face, particularly in these small rural communities, are some of the things that I mentioned earlier. They're economic, social, and as I said, but I ill-defined emotional relationships with wood heating. And in fact, some of the indigenous communities that we work with, heating with wood has a important traditional value too. So that's the caveat, I think, to that general premise that it would be essential to eliminate all wood heating or biomass combustion heating. But on general principle, yeah, if it can be accomplished, if there are the resources to do it, and if the societal and economic impacts on homes can be mitigated without people sacrificing their ability to heat their homes, then it might be, it would be best.
We have I've received a supplementary question, also a little bit lengthy, but bear with me. Here's an example of a subsidy scheme for lower, excuse me, can't pronounce it properly, Lower Elwha Kalam Tribe, Port Angeles, Washington, showing how they cut energy costs by installing ductless heat pumps. One tribal elder reports being so pleased with the results, and that the heat pump is saving so much money and keeping the house so warm and dry that he hasn't used his wood stove all winter until they provided. Does this suggest that it might be easier to overcome perceived barriers to replacing wood stove with non-polluting heating than trying to reduce ambient PM 2.5 pollution by upgrading wood stoves and persuade owners to operate them correctly? Similar question.
Similar. I'm not sure I have a different answer. I mean, I do agree. Again, this is based on limited evidence, but there's no evidence base for suggesting that we can train homeowners to burn correctly to minimize emissions. It's a laudable goal, and equipped with the appropriate appliance, perhaps, and the appropriate training and support tools, it is a potential strategy, but it needs to be tested. So, yeah, I think the jury is out on whether on the strategies. In terms of the other strategy that was suggested there, I'm not familiar with that.
I just had a question.
Just one moment, giving the microphone was far better on the online recording.
I just had a question. You replaced with wood stove. Did you replace with a wood stove that had like a pellet burner, or something that was intrinsically much better and more controllable?
Right. So no, we just replaced a wood stove with a wood stove, right? So log burning stove. The key distinction is that they're either catalytic or somehow sort of secondary combustion. So it's just better technology. But as I said, that may be marginally better technology. Yeah. I mean, the problem, even in I'll go back to the Libby example, there, people did have the option to either, remove their wood stove entirely and without any additional financial incentive or supplement to convert to electric heat, for example. And a few homes did that. People could also apply part of their voucher to installing a pellet stove, and a few did that, but the vast majority of homes opted for traditional log style wood stove.
Any further questions in the room?
So you mentioned that the HEPA filter to keep the HEPA filters and follow up with them. Did the placebo get upgraded?
Say again?
So did the placebo of that get upgraded? Did they actually get HEPA filters?
Right. So everyone that participated in the study got a normal functioning air filter at the end of the study. Yeah, they did. But one more comment about that, since I didn't elaborate on this in terms of compliance, at least within the context of our study. So we monitored air filter use using kilowatt meters. So we were able to assess to what degree, on a percentage basis, they were compliant, with 100% being they used, yes, this particular filter used as much power as it should use if it was running continuously as we had prescribed to the home. But what we found is that the reduction, the indoor the improvement in indoor air quality was pretty robust to departures of 100% compliance. So even down to, 60% or even below 60% compliance, they were still effective looking at pre to post indoor PM 2.5. But the larger question is that sort of long-term thing, right? Like, does it after the next year or the following year, does that filter just wind up, stuck in a closet somewhere?
So does that suggest that people were actually using the smart?
That's a great question. I wish we had done some more sort of qualitative follow-up on that question, but we haven't. We do have opportunities that we could do that, because that would be intriguing. I would, particularly with some of the work that your group is doing, I'd be really intrigued to know, to see if that particular intervention could be timed in a way to correspond to times of the day that, that homes are being impacted, whether it's from an outdoor source or an indoor source, so that filtration unit could be set on automatic on-off in the times that it's important and less impactful to the home, to the residents.
Right. Anybody else? In that case, finally, I will give one more thank you to Curtis Noonan and invite everybody to keep an eye on our website and look out for the next webinar, which will hopefully be coming soon. Thank you very much.